Right, so now we're going to go ahead and talk about personality disorders and describing what a personality disorder is, and then we'll go ahead and go into the specific types. So the definition of a personality disorder is a long-standing and maladaptive pattern of perceiving and responding to other people and to stressful circumstances differently than what might be expected based on your personality. So these personality disorders commonly coexist with different psychiatric disorders such as depression, anxiety, and bipolar disorder, or they can occur on their own. So two key things to keep in mind about personality disorders are, one, they're ego-syntonic, meaning that they're acceptable to a person's ego. So they don't think that what they're doing is abnormal or wrong. And the second one is alloplastic. So they adapt by trying to alter the external environment rather than themselves. So even if what they're doing is very obscure or strange to the quote-unquote normal person, the person with the personality disorder believes that the world around them needs to change, not themselves. So these patients, basically, they are not interested in treatment. The only reason they'll usually show up is because somebody brought them. And they often use a defense mechanism such as acting out, projection, isolation, and passive aggression. So basically, in general, patients with personality disorders don't believe that what they're doing is wrong or don't believe that they need any treatment for their personality. So the DSM-5 criteria for personality disorders in general is, the first one is that it's a pattern of behavior that differs from cultural norms in more than two of the following ways: cognition, affectivity, interpersonal functioning, impulse control. Their behavior must be different in more than two of those ways. The second one is that the pattern is inflexible and consistent across a broad range of personal and social situations. The next one is that the pattern leads to clinically significant distress or impairment in social, occupational, or other important areas of life and functioning. So this might be seen in a patient that continuously loses their job. Maybe they're not sure why, and they always blame their employer. However, they can't hold a job or something like that. The next one is a pattern is stable and of long duration, and its onset can be tracked back to at least adolescence or early adulthood. The next one is that the pattern is not better explained as a manifestation or consequence of another mental disorder. And the last one is that the pattern is not attributable to the physiological effects of a substance or a medical condition. The treatment in general for personality disorders is psychotherapy. Again, when we go over the specific personality disorders, I'll explain if there's another or additional treatment option, but overall the treatment is psychotherapy for personality disorders. So going into the specifics, there are three clusters of personality disorders: cluster A, B, and C. So cluster A is the odd or aloof type. Cluster B is the dramatic or impulsive or erratic type. And cluster C is the anxious and fearful type. So let's go into cluster A, which is the odd, aloof, or eccentric type. So this includes schizotypal personality disorder, schizoid personality disorder, and paranoid personality disorder. So let's go into schizotypal personality disorder. So these patients are going to have odd beliefs or magical thinking. They're going to have unusual perceptual experiences, lack of close friends, ideas of reference, or they would be suspicious or paranoid. So these patients will maybe claim that they have magical powers. They'll be really superstitious. They might think that somebody is following them. They'll have poor interpersonal relationships and few friends. So these patients are not super social because of this superstitious mindset that they have, and the treatment, again, is psychotherapy. Schizotypal personality disorder is often a premorbid for schizophrenia. So a lot of people that initially start having schizotypal personality disorder will eventually develop schizophrenia. The next one is schizoid personality disorder. So this one sounds kind of similar to schizotypal, so it's important to understand the differences here. So schizoid is a little different in the fact that these patients are really flat. So they don't really desire any close relationships or enjoy close relationships. They demonstrate emotional coldness. They're indifferent to praise or criticism. They choose to do solitary activities, and they have little interest in sexual activities. So when you think schizoid, just think of a very flat, constricted affect, patients that really are not wanting to be involved in anything or anybody. Treatment for this is psychotherapy again, and this typically onsets in childhood. The next personality disorder is paranoid personality disorder. And this one is similar to schizotypal in the paranoia sense, however, less magical thinking here. So, patients with personality disorder will be suspicious of being exploited, harmed, or deceived by others. They worry about loyalty of friends. They're persistently bearing grudges, and they're quick to react angrily to perceived character attacks. So basically, patients with paranoid personality disorder just think everybody's out to get them. And although they do want friends, they worry about the loyalty of their friends. So patients with this might have muscular tension, they have inability to relax, they need to scan their environment at all times, they might believe that they're in danger, they have usually a pretty serious demeanor and goal-directed speech. Again, treatment for this is psychotherapy again, and this also has a common comorbidity of schizophrenia, more common in men than women, and can definitely cause occupational or marital problems. So now we're going to move on to the cluster B personality disorders, and these are the dramatic or erratic personality disorders. So this includes antisocial, narcissistic, borderline, and histrionic personality disorders. So the first one we're going to talk about is antisocial personality disorder. This one is patients that have a blatant disregard for others. They are impulsive, they fail to plan ahead, they violate social norms. Some examples would be like they urinate on the floor or they're smoking in the hospital bathroom. They have lack of remorse or guilt, they violate laws or rights of others, and they get in repeated physical fights. So this one, like we talked about in a previous video, a common comorbid or premorbid for this is conduct disorder, and remember that ADHD often goes along with conduct disorder. So in patients with antisocial personality disorder, you also want to think conduct disorder and ADHD. So on physical exam, patients might appear normal or even charming. They can have a really good history of lying, truancy, thefts, fights, not usually anxiety or depression. They're more manipulative. With antisocial personality disorder, symptoms appear to decrease with age, but not always. Treatment for this, again, psychotherapy. Symptoms typically begin by age 15, like we noted in conduct disorder, but the diagnosis of antisocial personality disorder cannot be made until the patient is 18. This is also commonly occurring with alcohol or another substance use disorder. So the next one is narcissistic personality disorder, and these patients typically are just very grandiose. They have fantasies of unlimited success and like a big sense of entitlement. They lack empathy. They're envious of others. They exploit others to fulfill their own needs, and they have a need for admiration. Physical exam or other findings you might see are a heightened self-importance. These patients are entitled, boastful, and unable to handle criticism. Relationships are typically fragile. They sometimes cling to their youth inappropriately. For these patients, in addition to psychotherapy, a mood stabilizer can also be used if this is a very severe case of narcissistic personality disorder. So the next one you're going to see is borderline personality disorder. These patients are emotionally unstable. They develop unstable interpersonal relationships. They tend to participate in impulsive behaviors such as suicidal gestures, frequent one-night stands. These are the patients that might be in a short-term relationship but then threaten that they'll kill themselves if the person breaks up with them or something like that. They have an intense fear of abandonment, recurrent suicidality or self-injury behaviors, and intense anger or difficulty controlling their anger. So again, these patients might have an unstable affect, low self-esteem, bouts of anxiety and depression that last a few hours, mood swings. They always appear to be in a state of crisis, unpredictable behavior. They just can't tolerate being alone, and tend to see people as either all bad or all good, so they'll either hate you or love you. Diagnosis for borderline personality disorder is commonly made by early adulthood, and you definitely want to do psychotherapy in these patients, especially because they are at a high risk of suicide. A specific type of therapy that is beneficial for these patients is dialectical behavioral therapy, and this focuses on the psychosocial aspects of treatment, basically acceptance rather than abstinence, and includes weekly 1-hour psychotherapy and 2-hour group sessions. So when you're thinking borderline personality disorder, you want to think dialectical behavioral therapy is a very common type of therapy used for borderline personality disorder. Again, a comorbid in borderline is major depressive episodes. So the last personality disorder in this cluster is histrionic personality disorder. These patients will be dramatic, they want to be the center of attention, and they usually have sexually seductive behavior. So these patients will typically wear very revealing clothing. They might be really loud and want the attention on themselves. For a physical exam, they'll generally be very cooperative. They will tend to exaggerate their thoughts and feelings. They might have very dramatic and theatric gestures when they're communicating, and again, typically will wear very revealing clothing. This is commonly associated with alcohol use disorder. Again, treatment here is psychotherapy. When you're trying to compare and contrast the different personality disorders, histrionic is kind of similar to borderline personality disorder. However, the histrionic personality disorder has much less associated with suicide attempts and psychotic episodes. So histrionic is just more center of attention, very sexually seductive type of personality disorder. So lastly, we'll go into cluster C, which is the anxious and fearful types. The 3 here are avoidant personality disorder, dependent personality disorder, and obsessive compulsive personality disorder. So avoidant personality disorder are patients that are unwilling to get involved with others unless there's a certainty of being liked. They'll view their self as socially inept. They'll avoid occupations involving significant interpersonal contact, and they'll show restraint in intimate relationships due to fear of being shamed. So patients with avoidant personality disorder do desire relationships, however, they're feared that they won't be accepted. So they tend to avoid close relationships because of that, even though they do desire them. For here, the main feature is they are feared to be rejected by others. Their main trait is they're very timid. Like I said, they desire companionship, but avoid relationships due to fear. They're afraid to speak in public, and they're just very nervous and tense. Again, a good type of treatment for this, like we said, psychotherapy, but a good way to get them talking to others is group psychotherapy. So that is a very good way to treat avoidant personality disorder, as well as if they're excessively anxious or depressed, an SSRI can be used as well. Again, this is similar to dependent personality disorder, like we're going to talk about next. However, in avoidant personality disorder, there is a greater fear of abandonment. So let's talk about dependent personality disorder. In these patients, they have difficulty making their own decision without excessive reassurance. They need others to assume responsibility for most major areas of their life. They feel uncomfortable or helpless when they're alone. They have difficulty expressing disagreement due to fear of loss of support. They go to great lengths to get nurturance from others, and they seek relationships for a source of care. These patients might be very passive, they lack confidence, they have a tendency to be in abusive relationships because they believe that being in the relationship is better than being alone. They will probably try to cooperate in a psychiatric interview, and they welcome specific questions. They are just very dependent on other people, mostly because they think lowly of themselves, so they depend on others for reassurance. In these patients, there's a pretty high risk of major depressive disorder if the patient loses the person that they're dependent on. Again, treatment here would be psychotherapy. The last one we're going to talk about is obsessive compulsive personality disorder. When talking about obsessive compulsive personality disorder, you want to make sure you're comparing and contrasting this from obsessive compulsive disorder. So there is a difference between the personality disorder and just the general disorder, so we'll talk about both. So for the personality disorder, These patients are preoccupied with details, rules, and schedules. They have perfectionism that interferes with task completion. They're very rigid and stubborn, over-conscientious, inflexible about morality. They're reluctant to delegate tasks or work with others unless it's done their way. And money is viewed as something to be hoarded for future catastrophes. So these patients will be very rigid, stiff, constricted affect, they lack spontaneity, they're serious, anxious, and they really want to be in control of the interview. Again, treatment here is psychotherapy. The main difference between the obsessive compulsive personality disorder versus obsessive compulsive disorder is that in OCD, or obsessive compulsive disorder, these patients realize the irrationality of their obsession and view the obsession and compulsion as unwanted behavior. However, when they have obsessive compulsive personality disorder, they don't view their personality or what they're doing as wrong. They view it as, this is how things are supposed to be. So I'm doing things right and other people are doing things wrong. Whereas in OCD, they view their obsessions and compulsions as something that does need treatment. This behavior is unwanted, so they do seek treatment more often than people with OCPD. So let's just quickly talk about obsessive compulsive disorder. So in understanding obsessive compulsive disorder, you need to know what an obsession and a compulsion are. So the obsessions are kind of the mental side of things, and the compulsions are the behavior. So an obsession would be a recurrent and persistent thought, urge, or image that are intrusive and unwanted that cause anxiety or distress. And then the compulsion would be the repetitive behavior that the patient feels driven to perform in response to the obsession. So if the obsession is, oh, I'm going to get sick, I don't want to get sick, the compulsion might be, I'm going to wash my hands 15 times every hour, something like that. So the average age of onset of OCD is late teens. Common comorbids include major mood disorders like major depressive disorder, anxiety disorder, obsessive compulsive personality disorder, or tics. This can be caused by genetics, premature birth, maternal tobacco use, physical or sexual abuse as a child. Basically, these patients just feel an anxious dread that accompanies the obsession, and the compulsion is done to reduce the anxiety. So let's talk about what the DSM-5 criteria for diagnosis of OCD is. The first is the presence of obsessions, compulsions, or both. The second one is obsessions or compulsions take up more than 1 hour per day. And the last one is that obsessions or compulsions cause significant distress or impairment. So again, people with OCD view their obsessions and compulsions as irrational, and they view them as unwanted behavior. They don't want to be doing these things, but they feel like they have to. Whereas in obsessive compulsive personality disorder, these patients don't view what they're doing as wrong. They're very strict and rigid and stubborn, and that's the way that they want to be, and that's the way they believe it should be. So let's talk about some common obsessions and some common compulsions. So some common obsessions, the first one, like we talked about, is contamination and germs, which is the most common. The next one is pathological doubts, like, oh, I forgot to turn off the stove, or I forgot to lock the door, and they'll go back and check like 10 times to make sure. The next one is intrusive thoughts. This is usually the only obsession that doesn't have a compulsion, so this might be repetitive thoughts of a sexual or aggressive act that is reprehensible to the patient. And the last one is symmetry. So this is basically the patient that will only have one brand of clothes or only wear one color, something like that. So common compulsions, like we said, checking to make sure the doors are locked, washing hands to make sure they're not contaminated, counting, confessing, or hoarding. Again, in these patients, we also might see signs of depression or anxiety, marital discord, or they'll be very precise and neat and put together. Treatment for this would be a combination of cognitive behavioral therapy and an SSRI. One condition that you want to keep in mind when you're seeing OCD type symptoms in children is PANDAS. And PANDAS stands for Pediatric Autoimmune Neuropsychiatric Disorders Associated with Streptococcal Infections. So picture a child that comes in with a strep throat infection 2 weeks ago, and now they're having these OCD type symptoms or tics. So this is not usually OCD, this is usually a response to the strep infection, and this disorder is called PANDAS. When you're thinking about the brain pathophysiology of OCD, OCD is usually due to the hyperactivity of the orbitofrontal cortex.